Peace, peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Ronald. Welcome. So, we pick up Chapter 10. Welcome, YouTube. Peace. We're here. Peace. So, Chapter 10. IPPB Therapy. Page 184 at the top for the playlist and all those reading along with us. IPPB therapy is defined as therapeutic application of inspiratory positive pressure to the airway, usually via mask or mouthpiece, by a competent therapist or technician. It must not be confused with IPPV, medical support of ventilation, inspiratory positive pressure, which is administered to support cardiopulmonary homeostasis. See Chapter 22. This chapter is not intended to be a refutation of medical literature condemning IPPB therapy, nor is it meant to be justification for the lack of convincing studies. Rather, it is an attempt to place the clinical application of IPPB therapy on a basis upon which the respiratory care practitioner may judge its effectiveness and utilization. Only under these circumstances can we hope to provide highest quality patient care at the least cost to the patient and society. IPPB therapy has been controversial for more than 3 decades. Those who demand specific physiologic evidence attesting the qualitative and quantitative benefits of IPPB must be reminded that to appropriately study the efficacy of treatment regimens, their administration must be standardized. While relatively easy to accomplish in pharmacologic studies, it is very difficult with mechanical and manipulative regimens. On the other hand, those who believe that IPPB therapy is effective must be reminded that unsubstantiated clinical impression and dogma are far from irrefutable fact. The efficacy of any treatment modality must be judged by how well it accomplishes its goals. Most clinical studies of IPPB have failed to make clear delineation of methodology from equipment, positive pressure breathing from bronchodilators, acute disease from chronic pulmonary function improvement, clinical improvement, or clinical effectiveness from cost effectiveness. It object If objectivity is to exist in the support of or non-support of IPPB therapy, reasonable and practical therapeutic goals must be clearly stated. Therefore, we shall begin the discussion by asking a very simple and straightforward question. What is IPPB therapy meant to accomplish? Physiology. Peace. Welcome, YouTube. Thank you for the likes and subs. We're pushing to 1,000. And this peaceful part of YouTube where we read books and learn from masters. Thank you so much. We are reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So we just entered chapter 10, as you see, right at the bottom of page 184. All right. Physiology. There are four documented physiologic effects of intermittent positive pressure breathing. The physiologic effects of IPPB alone, not in conjunction with medication or aerosol, are 1. An increase in mean airway pressure. 2. A decrease in the work of breathing. 3. Manipulation of the inspiratory expiratory ratio. And 4. An increase in tidal volume. The authors are unable to substantiate other purported physiologic effects of IPPB. Increase in mean airway pressure. Top of page 185. Any method of breathing augmentation in which the inspiratory driving pressure is provided by applying a greater than atmospheric pressure to the upper airway will result in an increased mean airway pressure. Thus, the potential for decreasing venous return results. Peace, highest heart love, Bob. Thank you for being here. Thank you so much. Yes, clinical application of respiratory care for the future respiratory practitioners, and we're giving it all away for free on this peaceful part of YouTube where we read books and learn from masters. Thank you so much. I'm Master Uriel Neville Riley, Master Fitness Trainer by trade. So thank you for reading with us. It's a high vocabulary, super high level, yeah. Medical. The work of breathing. Mechanical support of ventilation is, in part, the process of providing ventilatory power so the patient's ventilatory muscles can increase their work. See chapter 22. When an increased work of breathing exists, intermittent positive pressure may allow the same degree of physiologic ventilation with far less expenditure of muscular energy. This is true only while the therapy is being applied. There is no rationale for expecting the decreased work to continue after the therapy is ended. Manipulation of the inspiratory expiratory pattern. Appropriate application of IPPB may result in a stressed patient accepting and being comfortable with ventilatory patterns not tolerated during spontaneous breathing. In the presence of disease that alters normal ventilatory patterns, the proper application of IPPB therapy may restore more efficient physiologic ventilatory patterns for the period of therapy. This is true only in patients with appropriate disease entities, not healthy people. Ding! Very key. We always need to delineate stuff like this. You have to manipulate it more so in someone that has problems, not in healthy people. You don't want to alter with their breathing patterns. Peace, highest heart love, Marquise. Highest heart love. Peace, family. Doing it. We got through 500 subs. We're powered up. We did the grocery giveaway and had a wonderful meditation yesterday with Lori and Speed. And now we're flowing into Thursday. I have a Your Healing session coming up this afternoon. So, well, actually, this early a.m. So I made sure preparing. Thank you so much. See, and I use the palpitation, right, with the diaphragmatic breathing. That's why I have the vocabulary and understanding to be able to read this information. So, thank you so much for being here. Love to my mods, all my family and friends. I'll read that last line again. All right. This is true only in patients with appropriate disease entities, not healthy people. Increasing tidal volume. Here we go. Bottom of page 185. An individual afflicted with a disease that limits the depth of breathing can be given increased tidal volume with IPPB therapy. In some disease states, the increase in tidal volume may be as great as 3 or 4-fold. Although IPPB therapy may potentially increase tidal volume, it is not guaranteed to do so. Certainly, a given pressure limit does not assure volume delivery. Tidal volumes delivered by IPPB therapy should be measured. Two additional physiologic effects are less well documented, but must be considered in this discussion: mechanical bronchodilation, and collateral ventilation. Top of page 186. Still in the section 3 of bronchial hygiene as well of this book. To all that are reading, want to keep that in mind. This is chapter 10, IPPB therapy. I'll make sure I have it in the vocabulary as well in the description. Mechanical bronchodilation. The tracheobronchial tree possesses a potential of distensibility and collapsibility. This characteristic increases as the lumen size decreases. There is a tendency for the tracheobronchial tree to dilate whenever intraluminal pressures exceed extraluminal pressures. The greater the intraluminal to extraluminal pressures difference, the greater will be the degree of dilation. When IPPB therapy is appropriately applied to a diseased lung, there is a greater degree of mechanical inspiratory bronchodilation than that which occurs with spontaneous inspiration. Collateral ventilation. Ventilation of alveoli via pores of cone, see chapter 1, appears to take place in diseased lungs in which bronchiolar resistance is increased. It appears reasonable to assume that appropriate IPPB therapy may increase this collateral ventilation by increasing the tidal volume delivered and improving the ventilatory pattern. Clinical goals, middle of page 186. IPPB therapy may provide a significantly deeper breath, at physiologically advantageous inspiratory to expiratory patterns than the patient can produce with spontaneous ventilation. It is this statement and the facts contained therein that form the rational clinical basis for the application of intermittent positive pressure breathing therapy. Based upon available evidence and a preponderance of clinical experience, it is the author's opinions that the goals of IPPB therapy should be: 1, to improve and promote the coughing mechanism; 2, to improve the distribution of ventilation; and 3, to deliver medication. Each time IPB therapy is applied to the patient, a concise thought process should be formed about which one or combination of these goals is desired. Only then can the therapist be guided in his approach or her approach to the patient and in his or her delivery of the therapy for maximum benefit. In addition, only after concise goals have been delineated can the respiratory care practitioner evaluate the benefit of effectiveness of therapy, improve and promote the cough mechanism. Bronchial hygiene is greatly dependent upon the effectiveness of the cough mechanism. See Chapter 8. Essential to an effective cough is the ability to take as deep a breath as possible and to accomplish the optimum peripheral distribution of that inspired air by providing a slow inspiratory flow rate and inspiratory pause. Ding! We have to hit that here, right? Oh my, inspiratory pause. Wow. A patient in whom these capabilities are significantly limited may receive significant benefit from IPPB therapy. Top of page 187. An acutely ill patient who will not produce a vital capacity of at least 15 milliliters over kilograms may benefit from IPPB therapy to improve the cough. However, if the IPP delivers less than 75% of the patient's vital capacity, the benefit of the treatment must be questioned, since theoretically the patient should be able to spontaneously inspire as much or more than is being delivered by the IPPB therapy. We'll pause right here. No, keep going. Yeah. Okay. Keep going. Yes. I love it. I love y'all so much. Thank you. Please, thank you so much for reading books with us. We're doing it. We're pushing through. What a great day. Happy Thursday. Improve distribution of ventilation. Thank you, all the book lovers community, all those authors out there. We love you so much. Hey, bro, I love you. Oh, thank you, Marquise. I love you too. You know, we're going to say that in a bit. Let us sing. Thank you so much. Thank you for keeping the chat clean too. Divinely guided and protected. Appropriately applied IPPB therapy improves the distribution of ventilation in patients with ventilation perfusion mismatch. Nitrogen, washout studies, blood gas studies, and distribution of ventilation studies have concluded that IPPB therapy definitely improves the distribution of ventilation in the pulmonary disease patient. A corollary to this is that appropriately applied IPPB therapy should have a great potential in decreasing the incidence of postoperative electrolysis and pneumonia, as well as re-expanding electric alveoli, atelectic alveoli. Although clinical studies are contradictory and controversial, the authors have observed that when therapy is administered with expertise to the appropriate patient, the results are consistent and convincingly beneficial. An improved distribution of ventilation should be accomplished when a significantly diminished inspiratory capacity is present and or a rapid ventilatory rate is present. Very key. Deliver medication. Middle of page 187. Internal medicine depends primarily upon pharmacologic, pharmacology, pharmacology, therapeutics. It is not surprising that the internist has come to view IPPB therapy primarily as a means of delivering medication. The unfortunate consequence has been that the mechanical advantages have been ignored while an inappropriate emphasis seems to have been placed upon the pharmacologic aspects. When an individual is limited in his ability or to breathe deeply, there is a better distribution of drug if it is administered by IPPB as opposed to an hand nebulizer. However, in the individual who can breathe deeply, there is no advantage to IPPB administration over a hand nebulizer. When medication can be safely and conveniently delivered by means other than IPPB therapy, it is an unjustifiable expense to use IPPB simply as a means of administering a drug. It is the author's opinion that IPPB therapy should seldom be administered solely as a means for delivering medication. Much evaluation of IPPB therapy has been based upon its effects as means of delivering bronchodilators. Controversy exists whether or not there is an advantage in delivering a bronchodilator by IPPB versus hand nebulizer versus parenteral administration. The authors wish to emphasize that this is a question independent of the appropriateness of IPPB therapy. The need and desire for bronchodilator therapy must be considered separately from the use of IPPB therapy. We'll pause right here. Continue back. Page 188 at the top. We entered chapter 10. Thank you so much for being here with us. Woo! Woo! I'll make sure I add it to the vocabulary. I will get there. I don't always get there right when the entire uploading process is complete. So we give it time. Just like the information, right? It's most important to let it settle in. Okay. Shaking it up on YouTube. Reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for being here and entering chapter 10 powered up. We're ready to go. Hi, it's Heart Love. Thank you so much for being here, reading with us. I want you to have a wonderful, wonderful day. Hope you get to see the sun and how brilliant it is. Birds line up every day, no matter what. Expecting greatness, expecting the best. Love. Thank you so much for being here and reading with us. Love water. Cheers to all my friends and family, all my mods. Done it again. I love you so much. Shouts out to the YouTube family, like great Dr. Greg Carr. We love you. Marie Daniel Favors. We love you. Zaza Ali. We love you. Luke to the real. Oh, that's so high as heart. I love you. I love you. I love you. I love you. Thank you for reading with me. Thank you for breathing with me. Man, that's so much love. Thank you, thank you, thank you. Man, I love you too. You know it. I will see you soon. And we'll continue back with chapter 10, right? Shaking it up in the world. Reading books live on YouTube. Love to the book lovers community. It's hard love. I love you. You know I know. You know it. I love you. I'll see you soon, okay? Peace. Love you, Bubbles.